Welcome, everyone. I am Dr. John Burke from Rocky Mountain Cancer Centers, and I'm here with my partner, Chris Benton. And we are going to have a discussion today about the latest and greatest from the annual meeting of the American Society of Hematology, or ASH, which occurred in early December 2021. And so we're going to talk about some of the hottest issues in acute myeloid leukemia or myeloid diseases, and also about lymphoid diseases, specifically diffuse large B-cell lymphoma, follicular lymphoma, and chronic lymphocytic leukemia. And so without further ado, maybe Dr. Benton, we'll have you get started and tell us what was new in AML at ASH.
Yeah, thanks, John. I think this is good to have this kind of tableside chat, and we can do it virtually, we can record it, and hopefully people can go back and learn something from our conversation. So, there was some good data that came out at ASH. I would say that in AML this year, there was nothing that was absolutely earth-shattering. Nothing, moonshot or Mars shot, but there was a lot of good updated information. I think what's really great about where we're going in AML is that we're having more and more therapies that are available. And one of the big questions is, how do we combine these and how do we sequence these treatments? And so because of that, I think the most notable studies were those that had that tested combinations or sort of sequencing of therapies, so to speak. And so there were about 4 studies that I wanted to mention that were presented. One of these was from the European group that looked at IDH mutated AML, and the study was azacitidine plus ivosidenib versus azacitidine plus placebo. Ivosidenib, as you know, John, is an IDH1 inhibitor. And, we think that this is a really promising therapy in IDH1 mutated AML. There's not really been a large head-to-head study that's looked at this, and so this was reported by the European group. The azacitidine plus ivosidenib had an improved sort of composite complete remission rate, and the overall survival just dwarfed the overall survival of the azacitidine plus placebo group. So for mutated IDH1 AML, the overall survival with the addition of ivosidenib was around 24 months median survival versus about 9 months median survival without the ivosidenib. So the addition of that targeted therapy seems to be really important in these IDH mutated patients. We have not only talked about using doublets like AZA plus Ivo, but we've also thought that triplet combinations are probably quite beneficial as well. A single-arm study out of MD Anderson presented by Nick Short with azacitidine plus venetoclax plus gilteritinib in FLT3 mutated patients was quite promising. There were about 26 patients in that study. 11 of these patients were newly diagnosed. So this was upfront triplet therapy with hypomethylating agent, venetoclax, and a FLT3 inhibitor, gilteritinib. And the overall response rate in that study was about 67%. The 6-month overall survival was above 80%. These patients seem to do really well, especially when this is used in the upfront setting. And then there was also an update on azacitidine plus venetoclax. So this has become a standard of therapy, especially for patients who are intolerant of intensive chemotherapy. And this was presented by Dan Pollier down the street at the University of Colorado. And what was interesting about this study was that it was actually kind of a conglomerate study, but it looked at poor risk cytogenetics. So it was a sort of subgroup analysis. And interestingly, patients who had poor risk cytogenetics, if they had a TP53 mutation, AZA plus venetoclax did the same as AZA alone. But if patients had TP53 wild type, patients with AZA plus venetoclax did significantly better than patients without venetoclax. The study didn't really delve into minimal residual disease, and I think that's something that needs to be done in order to fully understand what the addition of venetoclax does. But this was pooled data and included about 550 patients, so it was quite strong in suggesting that poor risk cytogenetics patients with wild type TP53 actually do significantly better with azacitidine. And then lastly, there was a study that looked at CPX351, which commercially is known as Vyxeos, versus hypomethylating agent plus venetoclax. Again, this was a retrospective study, but it was actually quite large for AML. It was about 211 patients in the CPX351 arm and about 226 patients in the hypomethylating agent plus venetoclax. The interesting thing about this study is that the CPX351 group seemed to have better overall survival. The response rates were about the same between the two groups, but the CPX351 had improved survival. The interesting thing to me about this study was the subgroup analysis for TP53 mutated patients. These patients did seem to do significantly better with CPX. So maybe the chemotherapy group in this particular group of patients, if they can tolerate the Vyxeos, maybe this is a worthwhile sort of upfront kind of therapy to think about. So those were kind of some combination therapies and kind of probing these questions of which treatment do we use first, as well as the questions of how do we combine these newer agents with hypomethylating agents and doublets or triplets. And the data suggests that as we add these agents together, we're actually improving outcomes. There's one last study that I would mention in AML, and that is something that's kind of on the horizon, and this is the menin inhibitors. These menin inhibitors were developed actually at your alma mater at Memorial Sloan Kettering, I believe, and they're being used to target MLL rearranged leukemias, as well as NPM1 mutated AML and NPM1 mutated leukemias. And this was a single agent phase 1 trial for relapse refractory leukemias with these genomic and genetic abnormalities. There was about, I believe, 40 patients on this trial, single agent trial. The composite complete remission rate was around 44%, which is pretty good. And I think the really impressive thing was that 70% of those patients who responded actually had MRD negativity by either flow cytometry or by PCR. And so what this showed was that these menin inhibitors may be promising new therapies, a new sort of addition to the arsenal that we have for a particular subset of leukemias. And I'm looking forward to seeing how these studies develop. That was presented by our colleagues at Memorial Sloan Kettering, and the senior author was Gus Issa at MD Anderson. So we'll see how those therapies develop. So those were the 5 abstracts that I thought would be good to talk about from an AML standpoint. Yeah, it was a good ASH for AML overall.
Maybe I'll ask you a few questions about them. So you talked about the fact that adding ivosidenib to azacitidine clearly improves outcomes in those with IDH1 mutated AML, but we already knew that adding venetoclax to azacitidine does the same in kind of a more all-comer population of patients with AML not candidates for intensive chemotherapy. And so in these patients with IDH mutation, what's your approach going to be? Are you going to give everyone venetoclax AZA, or are you going to give them these IDH1 mutated patients ivosidenib azacitidine and save venetoclax for later, or vice versa? What's your approach going to be for those patients?
It's a great question, and we don't know the answer yet. My approach has been and probably will be for the near term that we start with hypomethylating agent plus venetoclax, and that we save the ivosidenib for later. However, what I think we might find over time is that the triplet combination may be better than either one of those doublets. And certainly, we need some data to support that. But the addition of these targeted therapies seems to be quite beneficial. The thing to know as a baseline from your question is that venetoclax seems to have some specificity in IDH mutated disease. And so this is already an approved therapy. This is kind of the most well-tested therapy, hypomethylation plus venetoclax. And so that tends to be where I start. But I think the direction we're headed is that, as long as the toxicity is tolerable. And by the way, I didn't mention, but in that study, AZA plus IVO had essentially the same toxicity, very similar toxicity as AZA plus placebo. So you're not adding much toxicity, but you're getting significant benefit by targeting that IDH1. So that's my general approach as of now, but I think this is an evolving field, and we're going to see as we add these agents in and figure out how to use them together and sequence them, that we'll see better and better responses in this subgroup.
So let's talk about the triplet in FLT3 mutated AML, not candidates for intensive therapy. So my understanding was that there was a different trial that I don't think you mentioned that showed that adding gilteritinib to hypomethylating agent turned out not to be better than the hypomethylating agent alone. But we're seeing these promising results from the triplet of gilteritinib plus hypomethylation plus venetoclax. So for these patients with FLT3 mutated AML, do we have enough data to know that this is the way to go, or are you going to wait for a randomized trial before you begin adding gilteritinib to the ven-aza backbone for your patients?
For patients with relapsed refractory disease, I think that a lot of us are already using these kind of triplet combinations because you don't have much available. And some of these patients can tolerate this therapy very well. This has been tested, and in the study I mentioned, it was a relapsed refractory study. There was another study with the triplet combination with quizartinib, I think this is the direction we're headed. It's sort of like the AZA plus IVO study. We all suspected that this was going to be beneficial to patients, and the head-to-head study kind of, the doublet blew the single agent out of the water. But these treatments are not without toxicity, and so I think the choice of patient, you have to be careful. There was another study that looked at a FLT3 inhibitor and did not show as much benefit. And so, I think I did not present that abstract, but that data, I think there still needs some maturation of these studies. But in general, I think, we think that if we can add more targeted therapy without the toxicity, that these will end up being better.
And one final question, if I may. So with the addition of all these targeted therapies in patients not eligible for intensive therapy, how does that affect your utilization of the intensive therapies? I mean, these therapies have been curative for some patients with AML for a long time now. Has that changed at all? Or are you increasing your usage of the targeted therapies with hypomethylating agents more, or has there been a shift in the paradigm here? What's your general strategy, and what do you see happening in the field?
Yeah, it really depends on the patient. There's another abstract I didn't present, which actually looked at younger patients getting hypomethylating agent plus venetoclax up front. In other words, trying to avoid the toxicity that we see with intensive chemotherapy. And, this kind of analysis really suggested that intensive chemotherapy leads to greater toxicity, and maybe you get just as good a benefit in some patients with hypomethylating agent plus venetoclax. So, but I'll tell you that in my practice, last year at ASH, there was also a couple of presentations on an intermediate kind of approach with cladribine, low-dose cytarabine, and venetoclax. And this, to me, is one of the more promising approaches. It combines chemotherapy, some targeted therapy with venetoclax. It seems to be a well-tolerated regimen. It's not as intensive as some of the other regimens that we have. And based on historical comparisons, this is at least as good, if not significantly better, than our more intensive regimens. And so I think what we're seeing is that we're using these lower intensity regimens in younger and younger patients, kind of the mirror image of what we saw with pediatric ALL, where we were using intensive regimens in older and older patients to improve response. From the older patients, we're learning that we can actually use less intensive therapies in younger patients and preserve functional status quite a bit. So yeah, there's a lot of questions that remain to be answered, but it's an exciting time to kind of figure out which regimen and which approach is going to be best in each patient. And so we use a personalized approach, as you know, and as you do as well. So kind of depends on the situation, the molecular profiling in the patient, and this kind of thing. And so we always pick the thing that we think is going to do the best. I like that intermediate intensity regimen for patients, early 60s, I think is a range where we look, but we give it up, in patients up into their 70s, and I've given it to patients in their 50s as well. So
cool. All right. Well, great. Anything else on the myeloid stuff you want to share, or should we move on to lymphoid here?
No, let's move on to lymphoid. I just mentioned that there's updated data on using lower dose of dasatinib in CML. I think that data has matured very nicely. About 5 years of data that dasatinib 50 is maybe superior in terms of toxicity to dasatinib 100 milligrams. That was presented by Koji Sasaki at MD Anderson. And then in MPN, we're learning more about kind of baseline risk factors. It looks like that higher white blood cell count, just like higher platelets or higher red blood cells, higher white blood cell count is associated with thrombosis risk. And so we're making some incremental progress in kind of understanding how we can better treat younger patients in MPN. And so that's the myeloid space. Let's get to the lymphoid stuff. Why don't you start by just telling me kind of there was a lot of lymphoid stuff, I feel like, in ASH this year, and a lot of exciting stuff. It was definitely lymphoid focused in a lot of ways. What were kind of the top 5 or so trials in lymphoid malignancies that you would think were noteworthy?
Yeah, this was really sort of the year of diffuse large B-cell lymphoma for me at ASH. After many years of kind of a heavy emphasis on CLL and a lot of the progress being made in CLL, it was kind of exciting to see real progress being made in diffuse large B-cell lymphoma, which has kind of lagged behind some of the advances that we've seen in CLL. So
I feel like R-CHOP has kind of been
a
standard for a really long time.
Exactly. So for 20 or so years, R-CHOP has been the standard chemoimmunotherapy regimen for frontline management of DLBCL. So one big trial was called Polarics. And so Polarics studied an anti-CD79 targeting antibody drug conjugate in combination with chemotherapy. And so it was a randomized phase 3 trial where the control arm got R-CHOP and the investigational arm got polatuzumab vedotin plus what we call R-CHIP, which is basically R-CHOP minus the vincristine. Okay, so we dropped the one drug, vincristine, out of the R-CHOP. And that's because both vincristine and polatuzumab cause neuropathy. And so when you combine the two, there's too much neuropathy. So we dropped the vincristine out. There was a previous study that showed that Pola plus R-CHIP appears to work very well. So this was a randomized trial comparing the two. And indeed, for the first time in 20 years, we found improved outcomes in the investigational arm. Many trials have failed to do that between then and now, adding different drugs to R-CHOP. So this was really the first one in a long time that's shown a benefit. And the Pola R-CHIP arm had improved progression-free survival, lower risk of relapse. Fewer patients in the POLA group needed additional so-called salvage therapies like additional chemo, additional radiation, stem cell transplant, CAR T-cell therapies. And the cost in terms of toxicities really wasn't much different. There was a little bit of increase in febrile neutropenia with the POLA-R-CHP group. There was not an increase in neuropathy between the two groups. And I can tell you, because we treated a bunch of patients on that study, I really couldn't tell who was getting what. You know, we were blinded and the patients were blinded. And as a treating investigator, we couldn't really tell which patients were getting what treatment. It did not improve overall survival, presumably because we now have therapies that can save some of the patients who relapse with transplant, CAR T-cell therapy, et cetera. But I think it was represents a significant step forward in the right direction for these folks to reduce their risk of relapse. So as of today, it is not FDA approved. It is not listed on national guidelines. So we're waiting for more widespread adoption by regulatory authorities before we apply this to our clinical practice. But it may be that this, does become at least a new option for patients with diffuse large B-cell lymphoma. So that was a big trial. And then there were 3 trials that really moved the needle for relapsed diffuse large B-cell lymphoma. So the Polarics was frontline initial therapy. And in the relapse setting, the standard approach, again, for decades has been to administer a second-line chemotherapy regimen, and then in patients who respond to that, to give them autologous stem cell transplantation. So high-dose chemotherapy with autologous stem cell transplant. And we know that about half of patients who relapse then will go on to be able to get to a stem cell transplant. And so that's kind of the standard practice that we're in right now and have been for a couple of decades. Now, of course, CAR T-cell stands for chimeric antigen receptor modified T-cells. And for the audience, basically what happens is the patient's T lymphocytes are removed from their body. The blood is run through a machine. The T-cells are then sent off to a company that modifies these T-cells to insert what's called a chimeric antigen receptor, or CAR. And basically that makes these T-cells better able to target malignant B cells. And so then those T-cells are then sent back, reinfused into the patient, and they can attack the malignant cells. And so CAR T-cell therapies have been approved for the last few years as a third line or beyond treatment. So for folks who relapse, say, after a stem cell transplant, or who are not candidates for that. So these trials looked at using CAR T-cell therapy instead of stem cell transplant as a second line therapy for patients with DLBCL who've relapsed. So there were 3 trials that addressed the same question. They all included patients who had relapsed within 1 year of their R-CHOP or similar chemotherapy. So they were sort of high risk. They didn't relapse 3 or 4 years later. They relapsed quickly or didn't respond fully in the first place. So these were high risk group, not likely to do well with chemo. And so it was sort of selected for that group of patients, and they were all randomly assigned. So half the patients got standard therapy and half the patients got a CAR T-cell product. So Zuma-7 used one called Axicell, Transform used one called Lysocell, and Belinda used one called Tisacell. And interestingly, the Belinda trial was a negative trial. It did not show any benefit to the CAR T-cell therapy as opposed to the transplant. But the other 2 trials, Zuma-7 and Transform, did show significant benefit, not subtle benefit, to using the CAR T-cell therapy instead of the conventional approach. So I think the field is going to change here. Once again, we're waiting on regulatory approval, establishment on national guidelines. this is a costly treatment. These CAR T-cell therapies are costly, so we're going to need, plans for insurance authorizations once they get on these guidelines. So as of today, it's not available, but one would hope that, within the fairly near future, 6 to 12 months, this will probably be established as the new standard for patients with diffuse large B-cell lymphoma.
Now, Belinda was the product that was used took a little bit longer to manufacture, is my understanding. Do you think that was the responsible factor for why it was not beneficial in that group of patients, or was it the population?
There are a number of reasons why it might have been a negative trial, whereas the other two were positive. And I think one theory is that. Another theory is that the patients on the Belinda study were given more chemo as so-called, what we call bridging therapy, where you're trying to control the disease in order to get patients to the CAR T-cell therapy. And maybe that added chemo, even though they were on the CAR T-cell arm of the trial, might have prolonged the delivery of the CAR T-cell or delayed the delivery of the CAR T. They might have been less favorable patients because their treating physicians felt they needed chemo. They couldn't wait 3 weeks to get to the CAR T-cell therapy. So I think it's an area of active discussion as to why we have 2 strongly positive trials and 1 negative trial. But I think those are some of the theories about why this one was positive. So I think, unfortunately for Belinda, that particular product, T-cell, probably won't be utilized in this space, but the other 2 products, I presume, will become available and approved and become kind of the standard second-line therapy there.
Great. Any off-the-shelf CAR Ts that are on the horizon, or are these?
Yeah, there's a lot of investigation of those. I mean, I didn't see anything that would suggest those are ready for approval within the next 6 to 12 months. So for the audience, I mean, that's referring to CAR T-cell therapies that are not removed from an individual patient, but have been pre-made and are readily available at a manufacturer, and then can be ordered and just delivered to a patient. So those are in development. They have their own set of challenges. I don't see anything that's quite ready for prime time, but lots of exciting trials of those types of things. And I think in the long term, that is really important to try to increase the availability of cellular therapies for patients, because right now CAR T-cell therapy is not easy to get. Patients have to travel to transplant centers. It's very expensive. There's considerable toxicities. So there's a lot of room for improvement. And even in these trials, if you look at the outcomes in the second-line therapy of CAR T, a lot of patients were not cured. So there's still considerable room for improvement in management of relapsed large cell lymphoma. So another trial I think is going to be interesting is one called Sequoia, which is a CLL trial that looked at a new BTK inhibitor called zanubrutinib and compared it with a conventional chemoimmunotherapy combination, bendamustine and rituximab. Sequoia showed that zanubrutinib improved progression-free survival in patients with treatment-naive CLL, where this was their initial therapy. Not that this is a revolutionary thing, because we already knew that ibrutinib does this and acalabrutinib does this, but this will make another BTK inhibitor available for patients in the front line, and there are some toxicity advantages of zanubrutinib compared with other BTK inhibitors that might make it attractive for some patients. There's another CLL study recently reported called GLOW, which is an all-oral regimen of venetoclax plus ibrutinib that might be attractive for CLL patients who want to be treated with an all-oral therapy that's going to be time limited. So instead, right now the standards are all oral therapy with the BTK inhibitor that's continued indefinitely, or oral plus intravenous therapy with venetoclax and an anti-CD20 antibody that's time limited for a year or 2. But we don't have anything that's fixed duration or time limited all oral therapy. And so the approval of combo venetoclax and ibrutinib might be attractive for some patients. So And then, bispecific antibodies still are a very hot item in the B-cell malignancies. And we saw some data that makes us think that one might become available this year for follicular lymphoma called mosunetuzumab. Pretty strong data in relapsed follicular lymphoma. So these are some of the highlights in the lymphoid malignancies. So it's quite an exciting meeting.
Yes, I just want to get back one question about Polarics. So the overall survival wasn't improved, although there were some improvements in the anti-CD79 arm. Do you think it will be approved? It's kind of an opinion question. Do you think that this is? Do you think that this will become standard of care?
I think it will be approved. I think it will be a standard without the overall survival benefit. One could debate whether it will be the standard or whether docs will choose to give some patients R-CHOP and some patients Pola-R-CHP. It's certainly conceivable that that could be the scenario that emerges.
If it's an available therapy, what would guide you? Was there any subgroup that particularly benefited from this, or any patient that that might benefit more so than conventional chemotherapy with vincristine and so forth?
Yeah, it's interesting. So there were several subgroups where it looked like they got more or less benefit from the Pola-R-CHP. One of them was age, one of them was disease bulk, where the Pola-R-CHP didn't seem to help that much in bulky disease. In diffuse large B-cell lymphoma, there's a couple of different subtypes. So there's what's called the activated B-cell subtype for the audience, and there's the germinal center B subtype. And the Pola-R-CHP clearly improved outcomes in the activated B-cell subtype, but not in the germinal center B subtype. The problem here is that we've got all these different groups, and it's hard to know how many of these factors patients have to have. First of all, the study was not powered to show benefit or lack of benefit statistically in any of these groups. So these are, if you're a statistician, you say, well, these are hypothesis generating conclusions, but not, definitely decision-making conclusions. Do you need to have one? Do you have to have activated B-cell and be a certain age? Do you have to have activated B-cell and not have bulky disease? You have to have all of them. Do you have to have one of them? You have to, so it's tough to know how to apply those subgroup analyses to an individual patient. So I think docs might utilize some of that information in their decision making, but exactly how to do that, I'm not really sure. So I think my opinion as to what will happen, it hasn't happened yet, and I might be wrong, but my guess is that it will probably be approved and become one of the options that we use.
Cool. Well, a lot of good stuff in the lymphoid space, some cool stuff in the myeloid space. I think it was a good ASH overall. Would you agree?
Yeah, it was fantastic. And so hopefully, thanks to you for discussing with me. I learned a lot, as I always do every time I talk to you about these blood cancers.
Likewise. Yeah, it was very informative, and hopefully some people learned some stuff from our conversation. So
cool.
Well, thanks for joining, and we'll sign off now. And of course, we're always available for questions. If anyone sees this and wants to ask questions, just reach out.
Agreed.
All right. Talk to you later.
Bye-bye.